Is going to be on the role of the clinicians towards patient safety. And this is going to be by no other person but the champion, the founder, and the initiator of the multidisciplinary patient safety team of Gombe State. It started initially with the Federal Teaching Hospital Gombe, and now the State Specialist Hospital also have accepted the concept. And now we have a multidisciplinary patient safety team even within the State Specialist Hospital. And we used to have meetings together. Anytime when we are having meeting at the Federal Teaching Hospital Gombe, they join us and they are coming up. I'm happy to actually appreciate the medical director of the State Specialist Hospital for considering that patient safety as important. Because those by mere name, if you hear patient safety, you think we are talking about, we are talking about all encompassing components that can make a better healthcare delivery, protecting both the patients and the healthcare givers, and also with good results. So I am happy to let you know that Dr. Zainab Yunusa Kaltungo, who is the Chief Consultant Plastics and Reconstructive Surgeon, former head of department, the former chairman Medical Advisory Committee of Federal Teaching Hospital. She has been the founder and also has received a number of awards in relation to patient safety. So this August presentation regarding this topic, it wouldn't have been presented by no other person than her. So I think
Please permit me to stand on it. So that's my topic as was introduced, and I would like to say I've got nothing to declare. Next slide, please. Simply put, for those who might not be very familiar with patient safety is everything we do and or do not do to keep the patient safe. But I also like to put in a little bit of definition disclaimer here, that depending on where your orientation lies, the definition of clinician can range from the doctor to anybody, including the speech language pathologist and who. So, but my presentation covers everybody, because everybody, whether you're a health worker or not, as long as you come in contact with the health facility, is concerned with patient safety. So, as a clinician, your work involves you're having to act as a bridge between the patient and the other members of the healthcare team. For example, if you are a clinician and you want a drug given on the dot of 12 hourly, it is not enough for you to just give amoxicillin clavulanate 12 hourly. You must let the nurse know why you want it at the dot of 12 hourly and for which patient, such that when you have the persistent perennial problem of nursing shortages everywhere in the world, they know how to prioritize. They don't go and start from bed one, and then by the time they get to the patient who needs 12 hourly, he's more than an hour behind schedule. Again, let's assume you've given this first dose of amoxicillin clavulanate and the patient gets a very bizarre reaction. It is your duty as the clinician to walk up to the pharmacist and ask, could this be a problem with the batch of the drug? Could it be that this patient is having a reaction that was not previously documented? Do we need to change it? Do we need to can we get an alternative that is cheaper, pocket friendly for the patient, and so on? I think the message of that slide is clear. Next slide, please. So this slide, don't worry, I'm not going to go into everything on it. The part I want you to focus on, which a lot of my presentation will be talking about, is the part that says person-centered care. Next slide, please. ISQA, International Society for Quality in Healthcare, is shining refocused light on co-producing health. Something we already know, but some areas that we're missing. And that is to say that everybody is involved in producing healthcare. The patient, the cleaner, the clinician, the administrator, everybody is involved. And I'll tell you stories along the way. So this next slide, the part I want you to focus on is that part I have doodled on in red. That's a screenshot from one of the webinars from this one. And that acronym, the TIFCAP, stands for the individual formerly known as the patient. So for you, all you're seeing, you're on call, you have a patient, 40-year-old man, diabetic, hypertensive, with a necrotizing soft tissue infection, and he's very bad. Just cast your mind back. Who was he before he became your patient? Could he be the father of the bride who's supposed to give his daughter away next week, and if you do not treat him properly, might have to cancel the wedding or will leave the daughter very disappointed that her father couldn't be there for the wedding? Could he be a driver that if he doesn't get discharged early means that the family cannot feed? Or could he be a young man who's supposed to go and sit for his exams and might mean another year for him? So every time you come across any patient, please think of TIFCAP. Thank you. Next. So the bulk of my presentation will be on this slide. I'll be telling stories. And as I'm telling the story to illustrate patient safety, I would like to use the platform of this wonderful work done by this person called Tim Clark on the 4 stages of psychological safety. And he says there are 4 levels, starting with inclusion safety all the way to the best, which is challenger safety. Simply defined, he's just trying to say, whoever you are, whatever your cater in the health sector, whether you're top level, mid-level, or low-level cater, everything you do, you should make others feel included. Safe to learn, safe to contribute, and safe to challenge the status quo. So let me start with this first story, the physician and the patient. This one happened to me personally. It's been more than 3 years, and it haunts me till today. So we had this young man who was about 38. He was at that admission that he was found to be diabetic, had a really horrible wound, and of course could not afford anything. And as my units we want to do, we tend to contribute for the patients, and because we've been beaten badly before, we do not give the cash to the patient. So we know he cannot afford food. We go and negotiate with them at the canteen and we pay to them. So we know the food gets delivered to them. We buy them dressings. So you can imagine our consternation when we came for the ward round, and the nurse was upset that this patient doesn't eat. She cannot administer the insulin. And then we were upset. Well, in fairness to us, we were very polite to him, and then we admonished him. We're feeding you, we're buying you dressings, we're buying you drugs. Why are you not eating the food? Is it the quality of the food? And nicely, the patient said something that today will continue to haunt me. He said, and that was the last I heard from him. Because what happened was that by that evening, the nurse came to give him, and then he showed her the plate he had eaten. She jabs him the insulin. He develops fatal hypoglycemia. When we found out, when we bring him 3 meals, he pours it into a plate, gives it to the wife to go and feed the kids at home. I'm not saying the patient would not have died, but I probably won't feel as guilty if he hadn't died from iatrogenic causes. Maybe if we had just taken the time to sit down and find out what the problem was, he probably would not have lied to the nurse. So the things we do and or not do to keep a patient safe, patient safety. Second story, the story of the physician and the physiotherapist. When you get sporadic patient safety issues, we normally will speak with the person involved one-on-one. When we start to get a series of them, we tend to sit down with the unit involved and then find out what the problem is. So in this case, we had a series of cases from the physiotherapy department, patients getting burns from maybe like you grafted an area and the area doesn't have sensation yet. They leave them on ultrasound for too long and then they dissociate burns, and then you have to start managing the burns and you forget the physiotherapy. You just imagine that stiffness is setting in. And then we were now getting series of cases, including people who have like contractures developing tears over the wounds because the physiotherapist was, sorry to use the word, overly aggressive in trying to get the joint to straighten. And when we went there, I was dumbfounded, and those of you who know me know that I'm hardly ever short of words. I had no reply for the physiotherapist, a very senior one, when he said in the line of his duty, if he doesn't see blood during physiotherapy, he's not achieving anything. There was little I could say other than saying, please be careful. But as recent as 10 days ago, we still had a case of somebody who, indigent patient, we had to contribute social welfare came in to get the wound healed, and of course had developed some contracture because of late presentation. And the wound that had healed over the elbow was ripped open. Things we do, and or things we don't do to keep a patient safe. Again, the next story, the physician and the nurse, a case of near-miss medication error. This one emphasizes the importance of involving the patients in the treatment, especially patients who are not as educated to understand the treatment. But if you come down to their level, they understand. So this one is a happy story. So we had operated on this patient, and my unit tends to operate on Thursdays, our elective cases. So that means 48 hours it's weekend, and you know what happens weekends. Patients tend to fall between the cracks. And then we have told the patients that they're going to get intravenous medications for 3 days, and then on the 4th day, we'll convert you to oral. So, of course, in the night, nurse was overworked, came to give the medication, served the IV medication, and then served the oral one too, that the patient was not supposed to get until the 4th day. But luckily, because the patient had been involved, he kept the medication. He didn't argue with the nurse, kept it. And then until he was able to speak with one of the physicians on the team, and then it was explained to him. So you see why, don't assume that the patients are not important. Please involve them in every stage of the treatment. So this one ended well, and then we averted the medication error. Then the next one is about the physician and the OBGYN nurse, and this one I would advise that we all search our conscience, because there's a tendency for the healthcare worker to be paternalistic in everything he does. If the patient says, I don't want this, please do not force it on him, because most times they know the background to this. So in this case, this young ladies had allegedly walked up to this OBGYN nurse requesting family planning, and she asked if they were married, and they said they're not married, and she denied them. Whilst I'm not advocating promiscuity, but it is not your duty, it is not part of your job to deny them. If you cannot give it to them, please direct them to where they're going to get it. Or if there's somebody who's going to come to the shift after you, please let them go there and get it. Because, one, I'm sorry to sound crass, but life itself is a sexually transmitted disease. These girls will still have sex, whether they're married or not. And one or two things are possible. They will either carry the pregnancy to term and come up with children out of wedlock, who in our environments are likely to end up as Algerians, or she will get a criminal abortion. She will die. Which one would you rather happens? And each time, each one of us, you stop by a traffic light, and an Algerian comes and knocks on your window, let your conscience tell you, could this be the product of one of the people I denied family planning? And then for the last story, the physician and the fellow surgeon. So I'm part of a group of African female surgeons all over Africa. And then this general surgeon came one day, presented a case. She was more like thinking she had done right, and she expected to be patted on the back. But I don't think she was prepared for the response she got. So she's a general surgeon, had done hemorrhoidectomy for a patient, and second day post-op, she decided to go for the onward round at night, and then walked into the side room and met the patient. The patient is LGBT, and met him with his male sexual partner in the act. And she got so upset, she discharged him that night. Again, full disclaimer, I am not LGBT. I'm not advocating LGBT. But as a physician, if you have put your knife on the patient, the onus is on you to see that case to a logical conclusion. If, by your moral standards, you cannot do it, it is just right that you refer that patient to where he's going to get health care. I'm not a soothsayer, but I'm going to assume, that that this patient felt, oh, huge hospital in a huge urban setting, I got this public disgrace. By now, the story is everywhere, everybody knows me. So he's not likely to go for proper treatment. So think about the possibilities of what could have happened to this patient. Again, things we do not do, that will lead to the safety of the patient. And then for my last slide, I'll leave you with this quote from Dr. Tim Clark that says, "We thrive in environments that respect us and allow us to, one, feel included, feel safe to learn, feel safe to contribute, and feel safe to challenge the status quo. If we can't do these things, if it's emotionally expensive, fear shuts us down. We're not happy, we're not reaching our potential, but when the environment nurtures psychological safety, there's an explosion of confidence, engagement, and performance. Ask yourself if you feel included. Safe to learn, safe to contribute, and safe to challenge the status quo. Finally, ask yourself if you're creating an environment where others can do these four things. In the process, look around and see others with respect and fresh amazement. Find deeper communication in your relationships and more happiness and satisfaction in your life. Thank you very much.
Taskar lafiya.